Welcome back to the Deep Dive. Today, we are shifting gears completely.
We certainly are.
Usually we take a broad look at a topic, but today we have a very specific, high-stakes mission. We are stepping into the shoes of a postgraduate resident, preparing for the MD anesthesiology exams. We've pulled together a massive stack of textbooks. We're talking the heavy hitters like Miller's Anesthesia, Morgan and Mikhail, Guyton's Medical Physiology.
The Bibles.
Exactly. And specifically some exam-oriented review papers relevant to the Indian postgraduate context, keeping, the Gujarat University exam patterns in mind.
It is a formidable stack, but let's be honest, for anyone in anesthesiology, these books are everything. And this isn't just academic, this is survival.
Right. Our goal today is to synthesize this mountain of information into a single, high-yield, intensive coaching session. So I'm going to play the role of the exam candidate, nervous, maybe a bit overcaffeinated, and trying to keep all these numbers straight.
And I'll step in as the senior MD anesthesia faculty.
You're the mentor who's going to guide me through this minefield.
I am ready to be the professor, and let me tell you, if there is one topic that determines whether you pass or fail, whether you are safe in the OR or dangerous, it is this one.
Which is?
Lung volumes, lung capacities, and pulmonary function tests.
No pressure, then.
It is good pressure.
Right.
This isn't just about passing a Viva. This is the bedrock of our trade.
Okay.
Every time you induce general anesthesia, you are fundamentally altering the mechanics of the lung. You're changing volumes, you're altering compliance. If you don't understand the baseline, you cannot manage the changes.
You're flying blind.
You're flying blind. So take a deep breath, pun intended, and let's get into it.
Okay, let's start with part A, the introduction and exam framing. My first question is, why does this topic appear so often? I mean, looking at the past papers, it's just everywhere. Short notes, long questions, Viva tables.
It appears because it touches every single aspect of our practice. Think about it. First, safety. Every general anesthetic changes lung mechanics. You put a patient supine, you paralyze them, you have fundamentally altered their physiology. If you don't understand baseline volumes, especially functional residual capacity, or FRC,
which we'll get into.
Which we will absolutely get into, if you don't understand that, you don't understand why your patient is desaturating on induction.
So it's about understanding the why behind the hypoxia, not just reacting to a dropping number on the monitor.
Exactly. Then there's the preoperative assessment.
Right.
You have a patient with a lung mass. Can they tolerate a pneumonectomy? Can they even tolerate a lobectomy? You need PFTs, the pulmonary function tests, to answer that.
To stratify the risk.
Precisely. And finally, the ICU. Managing a ventilator is, at its core, managing lung volumes. We talk about the baby lung concept in ARDS, which is really just a concept of a drastically reduced aerated lung volume.
If you don't know your volumes?
You can't set the ventilator properly. You can't wean the patient safely.
Okay, so the examiners are basically checking if I can keep a patient alive, not just if I've memorized a textbook.
That is the bottom line.
Let's look at the exam pattern then. What am I likely to see on the paper?
Okay, so in a written paper, you will often get short notes on functional residual capacity,
FRC, yep.
Or flow volume loops, or closing capacity. Those are the absolute classics.
Yeah.
Then you might get a long question, maybe for 15 or 20 marks, asking you to say, discuss the preoperative pulmonary evaluation for a patient undergoing thoracic surgery.
And in the Viva, the oral exam.
Oh, this is a favorite opening topic. The examiner will hand you a piece of paper and a pen and just say, draw the lung volumes and capacities.
And if you hesitate there...
That's a very bad start. It signals a lack of fundamental knowledge. You have to nail that.
Right. So let's secure that good start, not the bad one. Let's move to part B, lung volumes. These are the absolute essentials.
This is the exam core. Now remember, there are 4 primary lung volumes. These are static volumes.
Meaning they can't be broken down further?
Correct. They cannot be subdivided. If you add them together, you get capacities. But let's stick to the 4 volumes first.
Okay. Volume number 1, tidal volume.
The most basic one. Tidal volume, or VT. This is simply the volume of air inspired or expired with each normal breath. Just quiet breathing.
And for the exam, I need values.
Always. You must give values. For a typical 70-kilogram adult male, it's approximately 500 millirel.
Okay.
But a better, more clinical answer is 6 to 8 milligrams per kilogram of ideal body weight.
Ah, ideal body weight.
Yes.
Why is that distinction so important?
Because fat doesn't breathe. If you have a patient who weighs 150 kilograms, their lungs are roughly the same size as when they were 70 kilograms. If you ventilate them based on their actual weight, you'll cause polytrauma. You'll damage their lungs.
Okay, that's a key clinical point. Ideal body weight. Got it. Next up is the inspiratory reserve volume, the IRV.
Right. So imagine you take a normal tidal breath in. Stop right there at the end of that normal inspiration. Now, inhale as much as you possibly can. Fill your lungs to the absolute maximum, that extra volume you just inhaled, over and above the normal tidal volume. That is the inspiratory reserve volume.
That's a pretty big tank, right? A big reserve.
It is. It's usually around 2,500 to 3,000 milliweller. It's your reserve for deep breathing, for exercise, for sighing.
Okay, so we have the air coming in. Let's go the other way. Expiratory reserve volume, ERV.
Same logic, just in reverse. You breathe out a normal tidal breath. Stop at the end of that quiet expiration. Now, force every last bit of air out that you possibly can. Squeeze it out until you can't push anymore.
Okay.
That extra volume you just exhaled is the ERV. It's usually around 1,000 to 1,500 milliweller. The sources vary a bit, so giving a range is a good idea.
1,000 to 1,500 milliweller.
Okay.
Got it. But here is the tricky one. No matter how hard I squeeze, I can't get all the air out. There's always some left.
Correct. And that is the residual volume, or RV. This is the volume of air remaining in the lungs even after a maximal forceful expiration.
You just cannot exhale this volume.
You cannot. It's about 1,000 to 1,500 millil, roughly similar in size to the ERV.
And this is crucial for the exam, right? The examiner is going to ask me why we have this air we can't use.
They absolutely will, and the answer is twofold. First, if we didn't have residual volume, our lungs would collapse completely at the end of every heavy breath. The alveoli would stick together.
So it prevents atelectasis.
It prevents lung collapse, yes. But even more importantly, it allows for continuous gas exchange.
Explain that a bit more.
Well, even when you aren't actively breathing in or out, blood is still flowing through the pulmonary capillaries. The RV acts as a reservoir of air, so that gas exchange, oxygen moving into the blood, CO2 moving out can happen continuously, smoothing out the peaks and troughs.
So you don't become hypoxic between breaths. That's a great way to put it. Continuous gas exchange.
Exactly. Remember that phrase?
Now, moving to measurement. I'm at the bedside with a patient and a simple spirometer. What can I actually measure?
With simple spirometry, you can measure anything that moves in and out of the lungs. So you can measure tidal volume. You can ask the patient to breathe in fully, so you can measure IRV. You can ask them to breathe out fully, so you can measure ERV.
But I can't measure the one that stays inside.
Exactly. Spirometry cannot measure residual volume.
Right, because it never leaves the lungs to be measured.
And this is the exam gold point. Because spirometry cannot measure RV, it also cannot measure any capacity that contains RV.
Okay, that's a critical link. Let's unpack that as we move into Part C, lung capacities. Capacity is just, what, 2 or more volumes added together?
Correct. Think of the volumes as the individual bricks, and the capacities are the walls you build with those bricks.
Okay, so let's start building. First, inspiratory capacity, or IC.
That one is tidal volume plus inspiratory reserve volume, so VT plus IRV. Physically, it's the maximum amount of air you can breathe in starting from a normal resting expiratory level. It's about 3,000 to 3,500 milliliter.
Right. Next up, vital capacity. This one seems clinically very important. I hear it mentioned all the time.
Vital capacity, or VC, is the big one for mechanics. It's the sum of 3 volumes, IRV plus VT plus ERV.
So basically, everything except the residual volume.
Precisely. It's all the usable air. The maneuver is take the biggest, deepest breath in you possibly can and then blow it all the way out until you're empty. That total amount of exchangeable air is your vital capacity.
And the value for that?
It's usually around 4,500 milliliter, but clinically we often think of it as 60 to 70 milliliter.
And you mentioned its importance in the ICU. Why do I need to know this number?
For weaning from the ventilator. When you want to extubate a patient, you need to know they have the strength to take deep breaths and to cough effectively to clear secretions.
And a cough is essentially a forced vital capacity maneuver.
It is. We generally say a patient needs a vital capacity of at least 10 to 15 milliliters to be a good candidate for a successful extubation. If they can only pull 5 milliliter, they're likely going to fail. They won't be able to breathe on their own.
Okay, that's a solid clinical pearl for the exams. 10 to 15 milligillimetry for weaning. Got it. Next is total lung capacity, or TLC.
That's everything, the whole lot. It's your vital capacity plus the residual volume, all the air the lungs can possibly hold.
Which is usually around
5,000 to 6,000 zile. And going back to our earlier point, since TLC contains RV.
You can't measure this with simple spirometry.
You cannot.
Okay. Now, we arrive at the heavyweight champion of anesthesia exams, the one you said I have to know inside and out, the functional residual capacity, or FRC.
Ah, FRC. If you remember nothing else from this deep dive, remember FRC.
So why is it so incredibly high yield?
Because it is the physiological definition of the resting state of the lung.
Okay.
FRC is the sum of the expiratory reserve volume and the residual volume, so ERV plus RV. In simple terms, it's the amount of air left in your lungs at the end of a normal, quiet expiration.
So when I'm just sitting here talking to you, between sentences, my lungs are sitting at my FRC.
Exactly. And physiologically, this is the crucial part for the Viva. It is the equilibrium point. It represents the perfect balance between two opposing forces.
What are those forces?
The lungs themselves have an elastic recoil. They're like balloons. They want to collapse inwards.
Okay.
But the chest wall, your ribs and muscles, has an elastic recoil that wants to spring outwards. At FRC, these two forces, the inward pull of the lungs and the outward pull of the chest wall, are equal and opposite. The whole system is at rest.
A state of equilibrium. And the normal value for this volume is?
Around 2,300 to 3,000 milliliter. Or, if you want to be more clinical, roughly 30 to 40 millioicoderms.
Okay, so why does the anesthetist care so much about this specific volume?
Because, and this is the phrase to use in the exam, FRC is your oxygen reservoir.
The oxygen tank.
It's your personal oxygen tank. When you induce anesthesia, you give drugs that stop the patient from breathing, you cause apnea. The only oxygen the patient has to keep their heart and brain alive while you are trying to secure their airway
Is the oxygen sitting in the FRC?
Precisely.
So a large FRC means I have more time to intubate before the patient desaturates.
Exactly right. We call it the apneic oxygenation time. If you have a healthy patient with a normal FRC that you've filled with 100% oxygen, you might have 8, maybe even 10 minutes of safety.
But if they had a tiny FRC?
Like in an obese patient or a pregnant woman or a small child, you might have 2 minutes, maybe 90 seconds before they turn blue. It's the difference between a calm, controlled intubation and a life-threatening emergency.
This leads us directly to the factors affecting FRC. The exam always asks this. What increases and what decreases FRC?
Yes, you need to know this list. Let's start with what increases it. FRC increases with height. Taller people have bigger lungs, more volume.
Makes sense.
It increases with PEEP, positive end expiratory pressure. We use that on the ventilator to literally hold the lungs open and restore FRC.
And what about age?
This is a classic Viva trap. Many students will say FRC decreases with age. It actually increases slightly, or at least stays stable.
Why would it increase? I thought everything got worse with age.
The function gets worse, but the volume can get larger. It's because the lung tissue loses its elasticity. It becomes like an old, stretched-out rubber band.
So it doesn't recoil as tightly inwards.
Correct. So the outward pull of the chest wall wins a little, and the equilibrium point, the FRC, shifts to a larger volume. Emphysema does the exact same thing, just to a much greater degree. You get a huge FRC, but it's useless air because of air trapping.
Okay, so that's what increases it. Now for the danger zone, what decreases FRC?
This is the list you really have to worry about. Number 1, the supine position.
Just lying down.
Just lying a patient flat. The abdominal contents, the stomach, the liver, the intestines, push the diaphragm upwards into the chest. This compresses the base of the lungs.
By how much?
Just lying down reduces your FRC by about 800 to 1,000 milliril. It's a massive drop.
Wow, that's a huge percentage of the total FRC.
It is. Now, add anesthesia. When you induce general anesthesia, you relax the muscles of the chest wall and the diaphragm. You lose that outward chest wall tone. The FRC drops by another 400 to 500 milliril.
So just between lying them down and putting them to sleep, we've lost maybe 1.5 liters from our safety tank.
Exactly, and you haven't even started the surgery. Now, what if the patient is obese? The heavy chest wall and abdomen compress the lungs even further.
Or pregnant.
The gravid uterus pushes the diaphragm up. What if they have restrictive lung disease? The lungs themselves are stiff and small. All these patients start with a dangerously low FRC, and we make it worse.
And this is exactly why we pre-oxygenate.
Yes. Pre-oxygenation is the act of denitrogenating the FRC. Air is 79% nitrogen. We are washing out all that useless nitrogen from that 2,500 milliliter tank and filling it with pure oxygen to buy ourselves as much time as possible.
That is crystal clear. Okay, let's move to Part B, pulmonary function tests, or PFTs. Why do we order these?
We order them for 2 main reasons, diagnostic and prognostic.
Okay.
Diagnostically, we want to figure out why a patient is short of breath or wheezing. Is it an obstructive disease like asthma or a restrictive disease like fibrosis? Prognostically, we want to know if they will survive the proposed surgery and the recovery period.
The bread and butter of PFTs seems to be spirometry.
It is the workhorse test. In spirometry, we focus on 3 key parameters from the forced expiratory maneuver.
Okay, what's number 1?
First, the FVC forced vital capacity. This is the total volume you can blast out after a maximal inspiration. It's the same volume as the vital capacity we discussed, just done with force.
Okay, total volume, number 2.
Second, the FEV1 forced expiratory volume in 1 second. This tells us about the large airways. How fast can you get the air out? It's a measure of flow.
And the third, and most important.
The third is the ratio of the two. The FEV1-FVC ratio. This is the critical differentiator between obstructive and restrictive disease.
What's a normal ratio?
Normally, you should be able to breathe out at least 70% to 80% of your total vital capacity in that first second. So a normal ratio is greater than 0.7 or 0.8, depending on the guidelines.
Okay. There's also another parameter I see on reports, the FEF 25-75%. What's that about?
That's the forced expiratory flow during the middle half of the FVC. It's important because it is considered effort independent.
What does that mean?
It means it's less affected by how hard the patient tries. It mainly reflects the condition of the small airways. It's often the very first thing to become abnormal in early obstructive disease, like in a young smoker.
So it's a marker of early small airway disease.
Exactly.
Now, for the visual learners and for the diagrams we have to draw in the exam, we need to talk about the flow volume loop.
This is very high yield for OSCEs and VIVAs. Imagine a graph. The vertical y-axis is flow, the speed of air. The horizontal x-axis is volume.
Okay, I'm visualizing it. Flow versus volume.
Expiration is the top part of the loop. Inspiration is the bottom. When you blast the air out, the flow shoots up rapidly to a peak. That's your peak expiratory flow rate, PEFR.
Right.
Then, as your lungs empty and the airways start to narrow, the flow decreases in a fairly straight, linear fashion until you hit residual volume.
So a normal loop looks like maybe an inverted ice cream cone or a sharp triangle sitting on top of a rounded semicircle for inspiration.
An inverted kite or a triangle is a very good description. Rapid rise, straight line decline. That's a normal expiratory limb.
Okay, now let's apply this. What does the loop look like in obstructive disease like COPD or asthma?
In obstruction, you can't get the air out fast. The airways are narrowed, so first the peak flow is lower, but the really characteristic sign is that the descending limb becomes concave. It looks scooped out.
Scooped out, like someone took a bite out of the side of the triangle.
Precisely. That scooped out appearance is the pathognomonic sign of obstruction.
Scooped out equals obstruction. Got it.
Ah.
Now, what about restrictive disease like pulmonary fibrosis?
In restriction, the lungs are stiff and small, but the airways are often held wide open by the surrounding fibrotic tissue. So flow is actually pretty good, even fast, relative to the small volume.
So what does the loop look like?
It often looks like a witch's hat. It's tall and narrow, or you could describe it as a normal-shaped loop, just miniature, and shifted to the right on the graph because all the lung volumes are reduced.
Okay. Witch's hat, or a miniature loop, equals restriction. Now, for the really tricky ones that examiners love, the upper airway obstruction.
Yes, these are classic Viva questions. Let's start with a fixed obstruction. Think of something like a tracheal stenosis or a scar from a previous tracheostomy. The narrowing is rigid.
So it affects air movement both in and out.
Exactly. Air can't get in fast and can't get out fast. Both the top expiratory loop and the bottom inspiratory loop are flattened. It looks like a box or a rectangle.
A box shape for a fixed obstruction. Simple enough.
Right. Now, what about a variable extrathoracic obstruction? Extrathoracic means above the thoracic inlet. Think vocal cord paralysis or laryngomalacia.
Okay.
This type of obstruction affects inspiration more. When you breathe in, the negative pressure inside the airway tends to suck the floppy tissues together, making the obstruction worse.
So inspiration is limited.
Yes. The bottom loop, the inspiratory loop, is flattened. Expiration is often normal because the positive pressure pushes the tissues apart.
And the opposite would be variable intrathoracic obstruction.
Correct. Intrathoracic means below the thoracic inlet. Think of a tumor in the lower trachea. During expiration, the positive pressure in the chest squeezes the airway, making the obstruction worse.
So expiration is flattened.
Yes, the top loop, the expiratory loop, is flattened. Inspiration is relatively normal.
I use a mnemonic for this. Extra in, intra out. An extrathoracic obstruction affects inspiration. An intrathoracic obstruction affects expiration.
That works perfectly. And a fixed obstruction affects both. You must be able to draw these 4 loops.
Okay. We mentioned earlier that spirometry can't measure residual volume. So how do we actually measure it for a full PFT panel?
We have 2 main methods in the lab. gas dilution techniques, and body plethysmography.
Let's start with gas dilution. That's things like helium dilution or nitrogen washout, right?
Yes. The principle relies on the conservation of mass. For helium dilution, we use a known concentration of helium, which is an inert gas, in a known volume. The patient breathes this mixture in and out until it equilibrates throughout their lungs.
And then you measure the new, lower concentration of helium.
Correct. And since we know the total amount of helium didn't change, we can use a simple formula, C1V1 equals C2V2, to calculate the new total volume, which includes the patient's lung volume.
It sounds perfect. What's the catch?
It has one major flaw. It only measures gas in lung spaces that are actively communicating with the mouth and the spirometer.
So if a patient has severe emphysema with bullae, these big pockets of trapped air that don't ventilate well,
the helium won't get in there to mix. The test will therefore underestimate the true lung volume.
I see. So for those patients, we need the other method, the body box.
Body plethysmography. This is the gold standard for measuring lung volumes. The patient sits inside a large airtight box that looks a bit like an old telephone booth.
And how does that work?
It uses Boyle's law, which states that for a fixed amount of gas at a constant temperature, pressure and volume are inversely proportional. So P1V1 equals P2V2. By having the patient pant against a closed shutter, we can measure changes in pressure both at the mouth and inside the box, and from that, we can calculate the total volume of gas inside their thorax.
So it measures everything.
It measures all the gas in the thorax, whether it's communicating with the airway or trapped in bullae.
So in a patient with severe COPD, the body box will give a larger and more accurate lung volume than the helium dilution method.
Exactly. And that very difference between the two measurements gives us an estimate of the volume of trapped gas.
That's a great clinical point. One last test in this section, DLCO, the diffusion capacity.
Yeah.
What is that measuring?
It's measuring the ability of gas to transfer from the alveoli across the alveolar capillary membrane and into the red blood cells. We use a tiny, safe amount of carbon monoxide for the test because it binds so avidly to hemoglobin.
What kinds of conditions would reduce the DLCO?
Anything that reduces the surface area available for gas exchange, like in emphysema where the alveolar walls are destroyed.
Okay.
Or anything that thickens the membrane the gas has to cross, like in pulmonary fibrosis or other interstitial lung diseases. It's also low in anemia simply because there's less hemoglobin available to bind the CO.
Why do I, as an anesthetist, care so much about the DLCO before a big surgery?
Because it is a very powerful independent predictor of postoperative outcomes, especially for lung resection surgery. If a patient has a predicted postoperative DLCO of less than 40%, they have a very high risk of perioperative morbidity and mortality. It tells you how efficient the remaining lung will be.
Okay, let's try to synthesize all of this now into Part E, interpretation of PFTs. I'm looking at a report. How do I quickly spot the patterns?
The very first thing you should look at is the ratio, the FEV1-FVC ratio. That's your branching point.
Okay, so pattern 1, the obstructive lung disease pattern.
The hallmark of obstruction is difficulty getting air out, so their FEV1 is significantly reduced. Their FVC might be normal or slightly low, but the key is that the ratio will be less than 0.7.
Because the FEV1 drops much more than the FVC.
Exactly. Then you look at the lung volumes. Because they can't get air out, it gets trapped.
So residual volume is high.
RV is high, and often the TLC is normal or high. This is hyperinflation.
And what are the anesthetic implications for a patient with obstruction?
You must give them adequate time to exhale on the ventilator. If you use a fast respiratory rate, they can't get the breath out before the next one comes in. They stack breaths.
Which leads to auto-PEEP.
Yes, or dynamic hyperinflation. This can increase pressure in the chest, drop their blood pressure, and even cause a pneumothorax. So you use a low respiratory rate and a prolonged expiratory time, an IE ratio of 1.3 or even 1.4.
Okay. Now for pattern 2, the restrictive lung disease pattern.
The hallmark here is difficulty getting air in. The lungs or the chest wall are stiff. So their FVC is low. It's the primary abnormality.
And the FEV1.
The FEV1 will also be low simply because the total volume is small to begin with. But UT, and this is the key, the airways themselves are usually open, so they can get that small volume out very quickly.
Meaning the FEV1-FVC ratio is normal or even high.
Exactly. A low FVC with a normal or high ratio is the classic definition of restriction.
And the lung volumes.
Everything is small, low TLC, low RV, low FRC. All volumes and capacities are proportionally reduced.
And the anesthetic implications for restriction.
These lungs have low compliance. They are stiff. You will need higher pressures on the ventilator to deliver a reasonable tidal volume, and because their FRC is so low, they have no oxygen reserve.
They desaturate incredibly fast.
Incredibly fast. A few seconds of apnea and their saturation plummets. You need to be very vigilant. Using PEEP is often necessary to keep their small alveoli open.
What about a pattern 3? A mixed pattern.
A mixed pattern is when you see features of both. For example, a patient with severe COPD who is also morbidly obese. The obesity causes restriction, the COPD causes obstruction.
So what would I see on the PFTs?
You would see a reduced FVC, indicating restriction, and a reduced FEV1-FVC ratio, indicating obstruction. It's the worst of both worlds.
Okay, let's move to the real clinical meat. Part F, anesthetic implications, specifically preoperative evaluation. I have a patient scheduled for a lung resection. How do I use these PFTs to decide if they are fit for surgery?
This is a common exam scenario. We use a risk stratification algorithm, mainly based on the FEV1 and the DLCO.
What are the cutoffs?
As a general rule of thumb, if the patient's preoperative FEV1 is greater than 2 liters, or more than 80% of predicted, they are generally considered safe to tolerate a pneumonectomy, the removal of a whole lung.
Okay, 2L for a pneumonectomy and for a lobectomy.
If the FEV1 is greater than 1.5 liters, they can usually tolerate a lobectomy safely.
What if they are borderline? Their FEV1 is, say, 1.6L, and they need a pneumonectomy.
Then you have to go to the next step and calculate the predicted postoperative values. You use imaging to estimate how much functioning lung will be removed, and you calculate what the FEV1 and DLCO will likely be after the surgery.
And if those predicted post-op values are still very low?
If the predicted post-op FEV1 or DLCO is less than 40%, the risk is very high. At that point, the gold standard test is a formal cardiopulmonary exercise test to measure their VO2 max.
What's the critical value there?
If their VO2 max is less than 10-15 milliliter, the risk of perioperative mortality is extremely high, and surgery is often contraindicated.
Okay, let's talk about the effect of anesthesia itself on lung volumes. This has to be a core exam topic.
It is. The classic exam answer is this.
Okay, ready.
General anesthesia reduces functional residual capacity by 16 to 20% almost immediately upon induction.
Why? What are the mechanisms?
There are 3 main reasons. 1, muscle paralysis, especially of the diaphragm, allows the abdominal contents to push upwards into the chest. A cephalid shift of the diaphragm.
Okay.
2, you lose the muscle tone of the chest wall, which changes its shape and reduces its outward spring. And 3, you get atelectasis, or small areas of lung collapse. This is often worsened by using high concentrations of oxygen, which gets absorbed quickly from poorly ventilated alveoli, causing them to collapse.
And this reduction in FRC brings up another critical concept. Closing capacity, CC.
Yes. Closing capacity is the lung volume at which the small airways in the dependent parts of the lung begin to close during expiration.
And the problem is when FRC gets too low.
The problem is when FRC falls below closing capacity. If that happens, it means that small airways are closing during normal tidal breathing.
Which means the blood flowing past those closed airways doesn't get oxygenated?
Precisely. You get a VQ mismatch, or a shunt, and that leads to hypoxemia.
This sounds very relevant for the ICU and ventilation as well.
Absolutely. When we're trying to wean a patient from the ventilator, we look at their mechanics, we check their vital capacity, hoping for more than 10-15 millokilens. We check their negative inspiratory force, or NIF, which should be stronger than -20 to -30 centimeter H2O.
And the whole concept of PEEP on a ventilator
is all about FRC. We apply PEEP to restore the FRC, to push it back up above the closing capacity in order to prevent that atelectasis and improve oxygenation.
Okay. Let's move to Part G, exam integration, to wrap this all up with some solid exam tactics. How about a quick comparison table for a written paper?
Perfect. For obstructive versus restrictive disease, your table should have these key points. In obstructive, FEV1-FVC ratio is low, 0.7. TLC and RV are high GH due to air trapping. The flow volume loop is scooped out.
And for restrictive,
FEV1-FVC ratio is normal or high H. TLC and RV are low. The flow volume loop is a miniature version of normal or a witch's hat.
Okay, that's a perfect summary. Now for the common exam questions in Viva traps. Where do students most often fail?
Trap number 1. The FRC versus age question. As we said, students instinctively say FRC decreases with age. It doesn't.
It increases slightly due to lost elastic recoil.
Right. But the key is that closing capacity increases more drastically with age.
So the 2 lines on the graph get closer and eventually cross.
Yes. The closing capacity exceeds the FRC in the supine position at around age 44. It exceeds FRC even in the standing position at around age 66. This is the physiological reason why older patients desaturate so much faster in the recovery room after surgery.
That's a fantastic point. What's trap 2?
Trap 2. Imprecise definitions. Confusing a volume with a capacity. If you're asked to define FRC and you say it's a volume, you've already lost points. It's a capacity, the sum of ERV and RV.
Be precise with the terminology.
Always. And trap 3. Not knowing the normal values or the units. If you say FEV1 is 2, the examiner will ask 2, what? Apples, bananas. You must say 2 liters or 60 milliloki go.
Okay, let's talk diagrams. What diagrams must I be able to draw from memory in the exam?
You absolutely must be able to draw the spirogram, the classic wave diagram showing the 4 volumes and 4 capacities stacked on top of each other.
Got it.
And you must be able to draw the flow volume loops. At a minimum, normal, obstructive, restrictive, and the fixed upper airway obstruction box pattern.
Right. What about the west zones of the lung?
That's a good one to have in your back pocket. If the discussion moves towards VQ mismatch in relation to posture and lung volumes, it shows a deeper level of understanding.
Okay, Professor, let's do a final summary exam conclusion. Do the final rapid-fire high-yield bullet points to take away.
Let's do it.
Number 1.
FRC is your oxygen reservoir. It's the buffer against apnea. Spirometry measures flows and most volumes, but it cannot measure RV and therefore cannot measure FRC or TLC.
Right.
Obstructive disease is defined by a low FEV1-FVC ratio, less than 0.7.
4.
Restrictive disease is defined by a low FVC, but a normal or high ratio.
5.
General anesthesia drastically reduces FRC, which risks it falling below closing capacity, causing atelectasis and VQ mismatch.
And 6.
Remember, the key preoperative lung resection limits. A pre-op FEV1 greater than 2 liters is generally safe for a pneumonectomy.
This has been an incredibly dense but unbelievably helpful revision. Thank you, Professor.
Yeah.
To everyone listening, I would seriously recommend pausing right now and trying to draw those flow volume loops from memory. It's the only way to make it stick.
I completely agree. In the exam, whether it's written or oral, speak or write slowly and clearly. Define your terms first before you explain them. And always, always link the physiology back to the real patient on the operating table.
Excellent advice. Good luck with the preparation. We'll see you in the next deep dive.